Happy New Year to everyone. Just to let you know that this meeting will be recorded. As Rachel stated, please place yourself on mute and any questions, please place in the chat. Um, I am definitely happy to host my first COC meeting as your board chair. So again, thank you. So we will call this meeting to order at 10:04 a.m. Welcome again. Some of the agenda bullet points. Aaron will go over the PIT information, the COC funding committee solicitation, COC committee updates. Then we will turn it over to Matthew Baxter, and he is our special presenter for today, and will discuss the assessing Social Security benefits. And then from there, Rachel will discuss and talk about the House America. Our next topic is homeless system response during the uh, Omicron variant, and then we will end it off with the development training. Any questions in reference to the agenda? Okay, perfect. So I will turn things over to Aaron. Aaron?
All right, guys. So the first thing that we'll be going over is just a few COC business items. Number one being a 2022 point in time count. So due to a surge in COVID cases throughout the country, HUD's allowing COCs to complete the PIT in the last 10 days of February versus the last 10 days of January. That was presented to the board this past week, and they did vote to allow the PIT to be moved to February, and that was officially approved by HUD as of this week. So the new 2022 PIT dates will be the night of February 23rd and the morning of February 24th. So it still will be the last Wednesday and Thursday of the month, just in February instead of January. We've also pushed back the training date to allow for more volunteers to be able to sign up within that time frame. So the new training will be on February 9th at the same time it was originally scheduled, from 10 to 11:30. We've included the Zoom link there, which can also be accessed on our website as well. Right, you can go to the next slide, Felicia. Okay, to volunteer for the PIT. So just some information about the COVID safety precautions we will be taking. So we have ordered and received CDC certified N95 masks. So we will be providing those to any volunteer who is going to be with us that night and the next morning. We will also be giving out hand sanitizer packets. We'll be keeping the team small, no more than 4 to 5 people, and really only 5 if there are people who come in contact with each other regularly. We are trying to keep the team small to prevent community spread. And we will be doing outdoor launch sites this year so that people aren't congregating indoors as well. If you're interested in volunteering, there's 3 different ways that you can do so, and we have that information on the screen here. The first would be the Code Purple count, which would be going to our Code Purple night-by-night shelters throughout the state to survey any individuals who are staying there on the night of the count. We also have our unsheltered count, which volunteers will be traveling by vehicle and by foot to count any individuals or families that are staying in places not meant for human habitation. And then we also have our next day service locations, which will be places like day centers, libraries, clinics, food pantries, etc., where people go to receive services and in hopes of catching anybody that we might not have caught the night before. So if anybody has any questions about volunteering or the pit itself, you can go to our 2022 pit page, which is linked at the bottom of the slide here. And you are also more than welcome to reach out to myself or Felicia, and we can get you any information about the pit that you might need. For any of those who have already signed up to volunteer, you do not need to re-register now that the account has been moved back. We do still have your information, and we will just be reaching out going forward about more information and things like that. But you don't need to go and re-sign up. We did get that question a couple times, and you guys are all good. And we thank you for signing up when you did, in the light of what's going on in the community. So again, any questions about the pit, you can go to myself or Felicia. Right, and you can go ahead and go to the next slide. Right, the last part for COC business that I'll be covering is our fiscal year 2022 COC funding committee. The COC funding committee is a super important committee to the COC. They convene annually to evaluate, review, and select projects for the COC funding competition. All members need to be non-conflicted, meaning that they cannot receive COC funding because for obvious reasons, and they are appointed by the COC board. So all members are officially approved and voted on. I just have a summary of the roles and responsibilities that are required of the funding committee, as well as the time commitment, which would be March through November, approximately 1 to 3 meetings per month, 1 to 2 hours per meeting. And then there is independent document review, which is about 15 to 20 hours cumulative through the entire process. So if anybody is interested in being involved in the funding committee this year, or would like more information about the funding committee, please reach out to me as soon as possible. We are in the process of getting ready to launch the funding process for the entire year. So anybody interested in being on that committee should reach out as soon as possible. Right, and you can go to the next slide, Felicia. And I will pass it over to you.
Good morning, everyone. I am going to briefly cover some COC committee updates. First, we have the Advocacy and Policy Committee. Their next meeting will be on February 3rd. As of right now, they are covering House Bill 235, which is the Bill of Rights for individuals experiencing homelessness, as well as the development of a COC advocacy and policy plan. Next, we have also for the for the Advocacy and Policy Committee, we do need a chair. As of right now, we have our co-chair, Tony Sarzega, and we are looking for a chair to chair this committee. The next chair is the Racial Justice and Equity Committee, chaired by Kim Ellis and Paula Witcher. Their next meeting will be on January 27th. As of right now, they are covering Racial Justice and Equity COC Education Initiative, as well as a statewide racial justice policy forum, and focused on affordable housing initiative. Next, we have our Service Solutions Committee. As well, we need a chair for that committee as well. Ruth Ann Messick is our co-chair for that committee, and their next meeting will be held on March 1st from 10 a.m. to 11. As of right now, they are working on workforce development / job training webinars, as well as increasing resources in Kent and Sussex counties. Next, we have the System Performance Committee chaired by Kim Brokenbraw. A co-chair is needed for that committee as well. Their next meeting will be on February 11th from 11 to 12. And they are currently focused on the 2022 PIT and HIT, focused on surveys and data, as well as the System Performance COC Improvement Plan. And then lastly, we have the Membership and Engagement Committee chaired by Brandy Nauman. We also are looking for a co-chair for that committee as well. Their next meeting will be held on March 9th from 10 to 11. And they are currently focused on developing a COC newsletter, as well as creating a COC social media platforms, as well as some targeted membership outreach. So that is just a brief update on all of our committees. I know we have a couple of our chairs and co-chairs on the meeting today. If you guys would like to add anything, please feel free to do so at this point. And lastly, if you are interested in becoming a member of any of these committees, as well as a chair or co-chair, please feel free to reach out to me. My email is listed here on the PowerPoint, or feel free to reach out to any of our chairs or co-chairs for any of the committees. All right. And if we don't have anything from any of our chairs or co-chairs, I will be next passing it on to Matthew Baxter. He is the Public Affairs Specialist for the Social Security Administration, and he will be presenting today on accessing Social Security benefits. You can take it away, Matthew.
All right. Well, good morning, everyone. My name is Matt Baxter. I am Social Security's Public Affairs Specialist for Delaware, as well as the Eastern Shore of Maryland and Virginia. I've been with the agency for about 15 years, and I provide a variety of services. I'm the agency's primary educator in throughout my territory. I also have a large email distribution list, so I send updates to folks who are on that list. If you're not on it yet, feel free to reach out to me. You can give me a call at 302-450-2292, or just email me. It's my first name, Matthew, followed by a period, last name of Baxter at ssa.gov, and just say, hey, Matt, add me to your list, and I'll be happy to do that. Also, I, especially during this pandemic, have been fielding service complaints and concerns. So if any of the folks that you care for make you aware that they're not satisfied with the service they're receiving from a field office in Delaware, feel free to reach out to me on that person's behalf. Let me know who's the impacted party, which office they're dealing with, if they have an employee name they've been dealing with, and basically what kind of resolution they are seeking. And then I will go ahead and forward that to local management. That way you don't have to tell the person to call us back, because I know it's very difficult right now getting through to the local offices as well as to our 1-800 number. So with that being said, we recently released kind of an infographic regarding how to go about getting help from Social Security until we resume our normal policies of in-office service. We don't know when that will resume quite yet. So I'm just going to read that information off to you so you can kind of jot that down before we get into the formal presentation itself. Social Security is here to help. We want you to know how to get the service you need and be prepared so we can help you as quickly and safely as possible. So the first step, whenever possible, is go online to ssa.gov. Our website is the best way for most people to get help. That being said, if you cannot use our website, either call the national 1-800 line, which is 1-800-772-1213, or call the local Social Security office to help. Here in Delaware, we have 3, one servicing each county. They're located technically in Newcastle, Dover, and Lewis. Finally, we will schedule an appointment for you, if necessary, to serve you by phone or in some limited situations in person. Now, if you have a client or someone you care for who does qualify for an in-person visit, be aware you have to have an appointment to visit the office. Masks are required for all visitors and employees, regardless of vaccination status. Visitor capacity is limited to follow physical distancing requirements. This means you may need to wait outside, so plan for cold or bad weather. We ask that you come alone unless you require help with your visit. If you require help, we can only permit one person to accompany you. We appreciate your patience and understanding. I also do want to clarify that one service we are not providing in the office under any circumstance is taking applications. So that's still being done either online or by phone. So just be mindful of that. But there are some limited circumstances where we cannot assist the person by phone or online. And in those situations, we can schedule an appointment for them to come into the office for a brief encounter. So with that being said, I'm going to go ahead into my formal presentation. I'm going to focus on some topics I feel is most relevant to you, and then certainly if you have any questions, you may ask those. So turning our attention to the slides,
Matt?
let's go ahead on. Yes,
Matt,
go ahead.
I'm going to go ahead and interrupt you before you move on to the other topics in your presentation, because there was a question in the chat about the accessibility of the physical offices. And I know you just talked about it, but could you go back to that for a moment and just clarify which offices,
Sure. So,
if the offices in Delaware are open and when folks should or should not physically go? If you could just repeat that again, I think that would be helpful.
yes, absolutely. So the bottom line is that the offices are still technically closed. We are not, open to the public. So if you were to go to one of the offices here in Delaware or nationwide, it's a nationwide policy, the front door would be locked. You would not be able to get into the office. So you always have to first seek assistance either online or by telephone. If you are not able to seek assistance online, and when you do get through to us on the phone, we determine that we can't help you by phone, that we have to help you in person. And there are very limited situations where that comes up, but it does come up. So in those situations, what happens at that point is that the local management team will evaluate on a case-by-case basis the request for in-person service. If the manager deems that, one, the request does meet our standards, and two, that they have sufficient staff in person in the office to help, the manager will then go ahead and schedule the appointment. And then at that point, of course, all of the policies I mentioned come into play. So basically, if you have to come into the office, make sure you're masked, and make sure you're bringing no more than one person with you to assist you. And this applies to all of our offices statewide and nationwide. So again, it's a process. You have to try to seek services online and by phone first, and then only if, again, we cannot service you online or by phone, that's when local management makes a determination of whether an in-person appointment can be made.
Thank you.
You're quite welcome.
Paul, did that answer your question, Paul?
Well, this is above his pay grade, but I think it's absolutely appalling that the Social Security offices are closed when we're in an emergency and people need us the most, and other offices are open, both private and public. And I just think it's a poor way to serve people, and it's a decision made above his pay grade. So it's just I find government should be open in an emergency, not closed.
Definitely understand the sentiment. So any other questions or concerns about that piece?
No,
Okay.
you can
All
do the
right.
presentation. Thank you, Matthew.
No problem. So let's just go ahead and move on to the second slide, so the one off the title slide. So the first topic I want to talk to you about is our disability program. So we're here with you when the unexpected happens. Of course, it goes without saying, we all want to work until we are financially stable and can retire on our own accord. But of course, we sometimes run into medical issues that makes that impossible. So that's where the Social Security Disability Program comes into place. As many of you are aware, we offer two disability programs. So I'm going to talk about both of those briefly. Next slide, please. The first disability program is under the Social Security program itself. So Social Security Disability provides a monthly benefit to people who are no longer able to work because of a significant disabling condition. Social Security does not pay partial or temporary benefits. So one important thing to keep in mind is that Social Security benefits and SSI disability benefits, which I'll mention in a moment, they are long-term disability benefits. So if you just have a person that you're trying to help who has a condition that's going to keep them out of work, but it's going to probably only keep them out of work for less than a year, this would not be the program for them. They may certainly still apply. Keep that in mind. You can certainly apply if you think there's any chance that you might be out of work or incapable of working for at least a year. But at the end of the day, that will be the determination that is made. Does this person have the ability to return to substantial gainful activity within 12 months of their onset? And that's an important concept to grasp as well. Again, I'm sure many of you already are familiar with SGA, but for those of you who are not, that limit changes year to year. It's the threshold over which, if you are deemed to be capable of being able to work, then you are not considered disabled by Social Security standards. And this applies both to adult decisions under the Social Security Disability Program and the SSI Disability Program as well. This year, the threshold is $1,350 gross per month. So again, if you have a client or someone you're caring for who applies for either of these programs as an adult, that is the criteria they'll be judged upon. Does this person, despite their impairments, have the ability within 12 months of onset to return to work where they will earn over $1,350 before taxes are withheld? So the disability program is for folks who, again, cannot return to work within 12 months and who are under their full retirement age. And for most folks now, full retirement age is 67. It used to be 65, and then slowly but surely, based on some reforms that were passed way back in 1983, that full retirement age was elevated to 67, and that's for anyone who was born 1960 or later. So if you're 18 up to 67 and you become disabled and you've worked recently under the Social Security program, you can then go ahead and apply for these disability benefits. Next slide, please. So for those who perhaps don't have enough work credits to qualify for Social Security disability benefits, or perhaps for minor children who are disabled, who are not covered by Social Security, in situations where either the individual or the family has low income and low resources, that disabled individual may qualify for SSI. So again, it's for folks who are between birth and age 18, so children who are disabled, who live in needy households, as well as those who are 18 to 65 who are disabled as adults based on the same criteria I mentioned on the last slide. And SSI is also there for folks who are 65 or older who may not be disabled. As long as you have financial need, once you turn 65, you may be able to qualify for SSI. Now, because of some reforms that occurred back in the 90s, oftentimes you need to be a U.S. citizen to qualify for SSI. You certainly have to be here legally to qualify for the program. There are some situations where permanent residents can qualify, but typically it is U.S. citizens who qualify for SSI, whether it's based on disability or based on age. Next slide, please. So again, many of you who have assisted clients through this process know it's not uncommon for the initial claim to be denied. So you do have appeal rights, okay? It's important that you file your appeal with us within 60 days of receiving the denial notice. If you provide it outside that 60-day period, you have to provide a good cause statement for why you were unable to file that appeal within 60 days. And then it's up to the Social Security employee assigned to that appeal request to determine whether or not good cause is actually met. Many of those appeals that are submitted outside the appeal period are denied for the fact they were not submitted in a timely fashion. Also, I want you to be mindful of the fact that Social Security employees are not the ones who make the medical decisions. That decision is made at the state level, and this is nationwide. Every state has a Disability Determination Service, or DDS for short. So there is a state-federal arrangement here where we take at the federal level the claims. We make all the non-medical determinations on whether a person can qualify, for instance, evaluating whether they're currently working while filing for disability. Assuming they meet all the non-medical criteria, we send it to the state government for a medical decision. They make that decision. They send it back to the federal level, the Social Security office, and we actually process that decision. So that's how that process works. And the same goes for the appeals. We take the appeals, but those decisions, medical decisions, as part of the appeal process is made at the state level until you reach the second level of appeal. This is when you're seen by an administrative law judge during a hearing. Those administrative law judges work directly for the Social Security Administration. So the first two determinations are made by the state. After that, it becomes a federal decision. And then if that decision is denied, it can go to an appeals council, which is still within the Social Security Administration. If the appeals council basically upholds the judge's decision to deny the claim, then the person has the right to turn it into a federal court case if the court is willing to accept that request or that appeal. Next
Hey, Matt.
slide.
I'm sorry to
Yeah.
interrupt you. There is a question in the chat. It says, what is the rate of approval after filing an appeal?
So I don't have the current numbers, but I can tell you from reviewing the numbers from past years, the level at which there is the lowest percentage of approvals is the first level of appeal, the reconsideration level that is still handled at the state level by BDS. Some years, that approval rate has been as low as 10%. And I think this is an important point to make because oftentimes, this is when people give up on the process. They file their claim, they get denied, they file an appeal, they get denied again, and they figure, what's the point of pursuing this any further? I can tell you that statistically, the greatest or highest percentage of cases are approved at the hearings level by the judge. There are a number of factors, including that a lot of the most serious cases go to the judge, whereas a lot of people who maybe are working part-time through some medical issues may give up prior to filing a hearing. That's just one of many reasons why, again, judges tend to approve cases at a higher percentage than are approved at the state level. So again, my message here is basically don't give up on the process. At least get your client or yourself, if you're dealing with a disability, get yourself before a judge, and then beyond that point, if the judge again denies your claim, there are further levels of appeal beyond that point. But again, initial claims tend to be about a third of those claims are approved. Again, this is on average, it changes year to year. About 10 to 15%, sometimes 20% are approved at the reconsideration level. And then the judges, again, it really does change year to year, but oftentimes somewhere around the 40 to 50% approval rate. But again, I have not looked at the most recent numbers. Okay. Any other questions in the chat before we move on to the next slide?
Well, I think, Matt, we're going to ask that you kind of keep moving along for the sake of time at this point. And then there was another question in the chat, and maybe you could come back to it after you're finished, if that's okay.
All right. Yeah, so why don't we push on through, and then at the end, if there's still time, we can answer questions. And again, folks, if you have questions that we don't have time to answer today, you can certainly email me or give me a call, and I'll be more than happy to chat with you. All right, so moving on to the next slide. This is really an important point. For those of you who are dealing with the disabled population, perhaps people already on benefits, a lot of times people do have some residual capacity to do perhaps some part-time work, but they're fearful they're going to lose their Social Security and Medicare or SSI and Medicaid if they go back to work at all. So I just want to emphasize, we actually have a very powerful set of work incentives to encourage folks on disability to re-enter the workforce. You can find out more information at socialsecurity.gov/redbook. But again, regardless of whether the person you're caring for is getting Social Security disability or SSI disability, there are special programs there to help them protect their cash benefits and their health care through the government while also pursuing a re-entry to the workforce. And again, I'm more than happy to talk to you guys at length on an individual basis about those different incentives down the road. Next slide, please. The other program I wanted to focus on today is the Survivor Benefit Program. So we're there for you when you lose a loved one. Next slide after that, should be a chart there that shows who can qualify for survivor benefits. And I want to emphasize this point. Most people think of Social Security survivor benefits only in terms of widows and widowers. And as you can see, they certainly qualify. But on the other hand, it's really important for young families to know that their children are also covered under the survivor program. So in the worst case scenario where mom or dad passes away after having worked and paid Social Security taxes, that child can receive benefits until they graduate from high school. And perhaps for life, if the child is disabled, it is a significant benefit. What we essentially do is calculate what the parent's full retirement age benefit would have been had they lived full retirement age. And then each qualifying child can receive as much as 75% of that rate. So if mom or dad's benefit was going to be $2,000 at age 67, then the child could qualify for as much as $1,500. We can usually pay the full benefit to 2 children. If a parent leaves behind 3 or more children, there is a family cap, and we divide that cap evenly amongst the number of children who qualify. It is not uncommon for middle class and working class individuals, if they pass away, for that family benefit to entirely replace what mom or dad was receiving after taxes and wages. So it's not an insignificant benefit in many cases. Make your clients aware of that, especially those who may be in failing health who have young children. Again, disabled children can receive those benefits beyond 18 or high school graduation, whatever happens later. as long as they are found disabled by the standards I mentioned earlier for an adult, and that disability begins before they turn 22 years of age. Widows and widowers can file as early as 60 or earlier. They can do it as early as 50 if they are disabled at the time of their spouse's or ex-spouse's death, or they become disabled within 7 years of that death. And they can receive benefits at any age, including their 20s, if they're taking care of the child they had with the deceased worker, and that child is younger than 16, or the child is 16 or older and disabled. I did mention ex-spouses. Yes, you can qualify for survivor benefits on your ex's record. There's a lot of ifs, ands, or buts, but the big one is you have to have been married for at least 10 full years before your divorce is finalized, and you cannot be remarried prior to the age of 60. So if you were married for more than 10 years, but you find yourself remarried at the time of your ex's death, you'd have to wait for your current marriage to come to an end to be able to file for benefits on that person's record. But if you remarried after you turn 60, once your ex passes away, you can file a survivor claim on their record. Next slide, please. There are two other benefits I'll cover very briefly. One is a lump sum benefit of $255 that is typically paid to the surviving spouse. If there is no surviving spouse, then if there is a child receiving benefits on the deceased parent's record, that child can receive the $255. And then there's another benefit that some of your clients may actually qualify for, and these are parents' benefits. So if you have a needy individual who is 62 or older, who has had a child pass away, their son or daughter pass away, that parent, depending on whether they were receiving at least 1/2 of their financial support from their child, they may qualify for survivor benefits on that deceased son or daughter's record. Again, there's a lot to this, so there's no guarantee that if you send your client to Social Security or have them call us to take an application for parents' benefits, there's no guarantee they'll be approved. But they should be aware that, hey, if they had a child who did pretty well and was helping them out in life, when that child passes away, that financial support is removed, obviously, they can try to file a parent's claim for survivor benefits on that child's record. Next slide, please. Other thing you should be aware of, and this is a very common thing that we take or do to assist those who have low income and low resources. Although we do not administer the Medicare program and we do not take applications for Medicare Part D plans themselves, we do take applications for extra help with Medicare Part D expenses for those who need that assistance. And it can be worth up to $5,100 a year. You go to ssa.gov/extra help to apply, or you call and schedule a phone appointment so that a local representative can take that claim over the phone. Next slide, please. In general, you can file online for retirement, spousal, disability, or Medicare claims. You cannot file a survivor claim online at this point. The other option is to call the 1-800 number to schedule a phone appointment to have a representative go through the application. At this point, again, we are not scheduling in-office appointments for applications, but that very well may change later this year. We do not, again, I don't have any information to share. I don't have any even inside information, but again, there is certainly a push to reopen the field offices, and we will see what happens. Again, you folks who are on my distribution list will be the first to know when that decision is made. Moving forward to the next slide, just want to very briefly touch on protecting you from fraud and abuse, Social Security related fraud and abuse. We can go ahead and move on to this slide after that. This says scam awareness and Social Security. It's important to know that even before the pandemic and certainly during the pandemic, we make plenty of legitimate calls from Social Security. So we do call individuals. So if you ever hear that, no, Social Security never calls anyone, that's incorrect. We do call individuals. The thing that you have to be mindful of, there are some red flags out there where you can kind of get a sense of whether a person is a legit employee or an impersonator. There has been a widespread gift card scam involving Social Security impersonators that has been going on for, 3.5 years or so now. Almost all of you have probably gotten one of these calls by now. Person will call and leave a message saying there's something wrong with your account, or there's illegal activity that has been discovered under your Social Security number, or your number has been compromised or suspended. If you don't call back, we're going to proceed with legal action against you. People who get scared and think this is legit, they'll call the scammer back. They'll be told, oh, there's a fee you have to pay to essentially make this all go away. Go down to the store and buy some gift cards for this amount. call us back with that gift card information. And folks, people are doing this. Tens of millions of dollars, if not $100 million plus, have been lost over the last 3.5 years in this gift card scam alone. The problem is, once you call that scammer back with the gift card information, they're going to drain that money off the card electronically, and it's treated like cash. We're not going to help you recover it, and usually the gift card company and the retailer who sold the gift card will not be able to assist. Once that money is gone, it's gone. So the best thing you can do is just tell your clients, if you ever get a call where they're threatening legal action or saying you should buy a gift card, it's 100% a scam. We never call people and threaten them with legal action. We never, ever ask them to pay overpayments or any other fees by gift card. So again, big red flags. Those are always scam calls. Just hang up the call on them. Next slide, please. Another way to protect yourself from scams and frauds is by setting up a My Social Security account. If you have not done so already, this is what our website looks like essentially at this point, ssa.gov. On the bottom left-hand corner, you'll see there's an option for My Social Security. It's an online portal through which you can handle your benefits. And for those of you who are not on benefits yet, you can kind of financially plan for the future. Next slide, please. For those of you who do not yet receive benefits, the two major benefits of the My Social Security portal is, one, it gives you access to the statement we used to mail you with your career earnings and benefit estimates. We only do that now for people who are 60 and older who do not have online accounts. So from 18 to 59, the only way for you to check to make sure your employer is reporting your wages and to keep track of what you're eligible for from Social Security is by establishing this online portal. Furthermore, you can request replacement Social Security cards. Now, here in Delaware, you do need a driver's license to use this particular feature. In most other states, you can also use a state ID. We are working with Delaware's DMV to hopefully eventually get that option online for Delawareans, but for now, it is restricted to those who have a driver's license. Again, you can use the rest of the My Social Security services without a driver's license. You just can't request a replacement Social Security card online. Next slide, please. For those of you and your clients who are receiving benefits, this is the main way that you can manage your benefits. So if you're getting Social Security, you can change your address, your telephone number, your direct deposit, and very importantly, whether you're getting SSI or Social Security, you can get your benefit verification letter online. You click a link, you hit print, and you have your letter. A lot of times people call this your award letter. So if you have clients who are verifying their income, this is the easiest way for them to do so, assuming they have access to a computer, either a smartphone, a computer at home, access to a library, etc. So those are the main reasons. Also, again, how this ties in with anti-fraud, anti-scam message. By setting up this account, you're ensuring that no one else, and usually it's not a stranger, usually it's an ex-spouse, an ex-boyfriend, ex-girlfriend, a mom or dad, a child, grandchild, someone who knows your financial business well enough to try to set up this account. There are people out there who try to create accounts for those in their circle, and they're doing it for fraudulent purposes. So you're ensuring by setting up the account yourself that no one else will try to set up that account for you. If you're not comfortable with setting up the account, there is another way to protect yourself, and that is by calling anywhere, the 800 line, the local office, or me personally. You can call me. I'm a Social Security employee. We all have access to block your access to our online services. So by placing that block on, it means that no one will be able to establish an account on our website. So the bottom line here is that everyone should be either setting up a My Social Security account, or for those who don't want an account or can't set up an account, they should be contacting us to put a block on their access to ensure no one else does. Next slide, please.
Matt, before we go to the next slide, I just want
Yep.
to remind you of the time, and just one more minute, please.
Sure. I will wrap that up just in about 2 minutes here. So these are the five steps for setting up an account. You can review those, and again, you can touch base with me if you're having any issues setting up the account. Next slide after that is enhanced security for your My Social Security account. So we do use multi-factor authentication. That means that you'll be sent a code every time you try to log into your account to ensure that even if someone else has your login information, they will not be able to access your account because they won't have access to your email address or your phone where that code is sent. And then the next slide, please. So this is what the sign-in process looks like. You enter in your login information, you're sent a security code, you enter that code, and then you have access to your account. And then the last slide, please. So I just wanted to provide this link to you. I would recommend that you all share this and save this as a favorite. This is a link to our regional calendar of events. Right now, we are still limited to providing outreach like I'm doing today virtually, but our hope is later this year that we will resume some in-person outreach, making presentations, participating in community fairs, et cetera. So please save this as a favorite. There are some virtual events listed now. It's updated every week. And as we hopefully return to some level of normalcy later this year, you should hopefully start seeing some in-person outreach events also listed. Anything listed on this calendar is both free and open to the public, no charge, but there also often is pre-registration requirements. So thank you for the opportunity. I apologize for going a bit over time, but again, you have my contact information. So if any of you have any individual questions or concerns, especially service concerns on behalf of your clients, please feel free to reach out to me. All right.
Thank you so much, Matthew. Just to confirm, Felicia, Aaron, or Rachel, were there any questions for Matthew before we move forward? I was trying to see.
There were a few, but I did re-enter Matt's contact information into the chat, as well as that link he just shared. So just for time, we do encourage everybody to reach out to him directly for any questions.
Can I
Perfect.
just jump in very briefly?
Yes, I was actually going to give you the
thank you.
floor. So thank you again, Matthew, for all of your information. Please check the chat for Matthew's information as well as the link. And I am going to forward everything over to John Whitlaw, who also works closely with Social Security Administration, and as she wanted to share just a couple few things. Thank
Yes,
you.
this is John Whitelaw from Community Legal Aid, and I promise to be about 1 minute. Hi, Matt. Matt and I have worked together on lots of things. I wanted just to add 3 very quick things. 1, to find out the local office phone number, the quickest way to do it is to Google the term SSA office locator. It will then ask you for a zip code, and then when you put the zip code in, it will tell you the local office and provide you with the local office phone number and fax number. 2, Matt said on disability cases, if you get denied, don't give up, and I agree with that completely. I also suggest that if you get denied, get a lawyer. Get an advocate to represent you in your disability claim. There are lots of private lawyers who do this. You end up paying, if you win, only out of the back money. And I will tell you, it is worth every dollar you pay them to win your case. And then the third thing that I wanted just to note is, while it is true that as a technical matter, the appeal deadline is 60, it's really 65 because it doesn't start ticking until 5 days after the date on the notice. Because you remember, Matt said it's 60 days after you receive the notice. And notice and the receipt is presumed after 5 days. So for practical purposes, not that you want to wait until the 65th day, you do not, but it is 65 days from the date of the letter from Social Security. And those were the only 3 things I wanted to add because I promised to be short.
Thank you so much, John. And I will now pass the mic to Rachel.
Thank you, Dana, and John and Matt and everyone. I think we could talk about helping our clients and the folks that you all serve access Social Security for hours and hours, and I think we probably should. And I think that's telling in terms of the types of questions that were in the chat. So we'll see about how making sure to continue to share this information and talk about how to improve access to those benefits for folks. All right, so I'm going to talk briefly about House America. So at our last Continuum of Care quarterly meeting, I talked briefly about it. I'm going to do it again today. It is a federal initiative that the Biden administration, the U.S. Department of Housing and Urban Development, under the Biden administration, is asking local leadership, local elected officials to sign on to, mayors, governors. In our case, we have a county executive who has officially signed on to the House America campaign in December, which is exciting. The idea is that HUD has put out some very clear guidance for local entities, local governments, to think about setting some really clear goals as it relates to how to use American Rescue Plan relief dollars to rehouse people experiencing homelessness into permanent, stable housing using a housing first approach, and how to build more units of affordable housing specifically targeted to meet the needs of people experiencing homelessness. So the goal here is that local jurisdictions would look at their resources, their American Rescue Plan resources, the federal relief dollars, their HUD relief dollars that have come through those mechanisms and other mechanisms, and really think strategically about setting goals to rehouse homeless folks and create more housing for that population. So we're excited that we have Matt Meyer, the county executive, that here in Newcastle County that has signed on. And just to let folks know that the process of setting those goals and working towards them is underway. This is just more information for you, same information presented at the last meeting. If you're interested in learning more about it or talking to your local government officials about it, your local county council or city or town council or leadership, there's some really easy to consume information on these websites about the House America initiative and recommendations about how to use these relief funds to make the most impact for people experiencing homelessness. So let's talk a little bit for the next, I'd say 20 minutes or so, and about what's currently happening in your world and in the world of the people that many of you are serving. So, you know, we all know, not saying anything new here, that lots of people are testing positive for COVID-19 in Delaware and have been for weeks. That may include you, your staff, the people that you're serving. But not only are people testing positive, there are also more people in the hospital than ever, and our health systems are really strained right now. This impacts not just some people, but it's impacting everyone. It's impacting organizations' ability to operate. It's impacting clients' ability to get access to help. And so I wanted to start with, and Felicia, you can go to, or I think it's Felicia, you can go to the next slide, to just remind folks, so HUD and the CDC have been putting out guidance. We've been trying to forward this information on to folks. Their guidance has really been, and they started putting this out in December, go back to what you were doing before. If you relaxed any of your COVID protocols in your homeless assistance programs, put them back in place. Make sure that you are keeping people distanced, to make sure you're doing all the things that they've always said need to be done. Now, when the CDC put out renewed guidance a few weeks ago on cutting down isolation periods from 10 days to 5 days, they actually put out separate specific guidance for high risk congregate settings, which includes congregate homeless shelters and homeless assistance locations. They are still recommending that residents who have been exposed to COVID-19 be quarantined for 10 days, as well as staff, and that facilities could consider shortening that time if there's a critical staff shortage, but should only do so in discussion with their local health departments. So while they did nationally announce this change to a 5-day quarantine or isolation period, they specifically in a homeless shelter settings, congregate settings for this population, have recommended the 10-day remain in place. Next slide.
Rachel, even if they've been vaccinated?
Yes, it specifically says regardless of vaccination status.
Because talking to public health this morning, they seem not to communicate that same message.
Yeah. So I think it's hard to kind of parse out a lot of the different segments of society and messaging for the CDC and the public health departments. The HUD specific guidance for homeless assistance providers. There are some links here that can take you there so you can review it, but it specifically talks about regardless of vaccination status, because the assumption is, well, we know at the national level anyway, again, talk to your local public health folks, maybe bring this up with them if you're concerned. But we know at the national level, and I think we know this at the local level, that people experiencing homelessness are are more likely to have health conditions that put them at risk and less likely to be fully vaccinated than other populations or subpopulations in our community. And so the guidance for that population is from the federal level is specifically different. Yeah, sorry to hear that there's a little confusion there. I will also just mention to those of you who are operating shelters and congregate homeless assistance settings, in addition to saying thank you and hang in there, I will also just remind you all about the importance of isolation space. Again, I know that this depends on the facility and what type of facility you operate and whether or not this is possible. But I think now more than ever, the guidance is encouraging homeless assistance providers and communities writ large. So to expand isolation space for people experiencing homelessness as a way to prevent hospital surge for folks because people experiencing homelessness won't have anywhere else to go if they can't go into a congregate setting because they're COVID positive, but even if they aren't sick enough to go to the hospital, right? So the idea is to prevent those folks from going to the hospital by having isolation. We know that here in Delaware, and we're going to hear from them in a few minutes, that DHSS is active in providing isolation units for people experiencing homelessness who are COVID positive. But for those of you operating congregate settings, just a reminder, if there's a way for you to make space available on site for new folks coming in as an isolation room or area, happy to talk with you more about that. There's a lot of HUD guidance around that, but I just wanted to remind folks that can be a really effective tool for preventing spread on site and kind of helping continue to be able to serve folks. So next slide. So again, infectious control measures remain the same. They're really encouraging communities to fully utilize all available non-congregate sheltering options right now to the extent possible. Maintain or re-implement distancing rules, make quarantine and isolation space available when possible. Continue, of course, to require masks regardless of vaccination status. And obviously, encouraging vaccinations and booster shots for the folks that you're working with. Those things haven't changed and are, continue to be recommended. So the other thing I'll just note real quick before I pass it over to our partners to talk about some of what they're seeing both in congregate and non-congregate settings is that if you haven't already done so, please contact your local federally qualified health center. There's a link that you can't access right now, but you will be able to when the slides are posted, but you can find out what your local federally qualified health center is if you don't know what it is. And the Biden administration has indicated that specifically that homeless assistance providers should reach out to these entities for access to rapid testing, that they're intending to, if they haven't already, push a lot of those resources through these sites and ask these sites specifically to partner with homeless assistance providers to get these rapid tests to homeless assistance sites. If you have not yet done so, we would encourage you to do so. I don't know what the current status of this is, but just sharing that message because I think the extent to which we can get you all can get your hands on those resources if you need them. Here's another place to look. And now I am actually going to, the next slide just includes some links to information and updated guidance. There is a webinar today at 1 o'clock if you don't have anything planned for this afternoon to talk about all this stuff in more detail. But I'm actually going to turn it over to John. So John Bates, who is the vice chair here of the COC and the deputy director of programs at the Ministry of Caring. As all of you know, the ministry operates a number of homeless assistance projects and types in congregate settings. And I asked John to just talk a little bit about kind of what they're seeing and challenges that they're facing. And John, I'm just going to hand it over to you.
Thank you. Good morning. Yeah, we're facing some challenges with the Omicron without a question. Now, I expect everybody else who's involved with emergency shelters doing the same. Even in the last week or two, we've had a number of cases in our shelters where we had clients come in who tested positive One of the challenges that we have is that I don't know if there's any screening going on prior to making referrals to homeless shelters now. Rachel, is there any screening process taking place? Because what we find is that we have folks coming to our shelter. We because of unexpected occurrences, we find out that they're positive for COVID. Many times they don't want to, they communicate, they don't want to share that information because they fear that if they communicate whether they're positive, they won't have anywhere to go. I think one of the things that emergency shelter providers need to do it and be prepared to do it is to let folks know as they come into the shelter that if they are positive, that we will develop a plan for you. So please share that information with us. Trust us to work with you to make sure you get the services that you need. Again, we have one shelter right now that we had a gentleman come into our shelter. We're in a communal setting in our emergency shelter for men. He was in a room with another man. He started coughing. The man started complaining about his coughing. We tested him. He was positive. As a result, he and 3 other residents are positive in that shelter. We tried to communicate with the state about that, and we're finding that we're willing to have those 3 gentlemen go to a hotel, but we found that hotels will not accept them. We're told that state do not have any additional isolation rooms available. So we're stuck trying to quarantine that entire program. And that is a challenge for us. We're going to have folks, we're going to have those men remain in their room. We're going to test them on a regular basis. We're going to have food brought to the shelter so they can be fed. So that is a challenge that's ongoing. We have this issue with staff as well. We have staff who are being catching this Omicron virus also. So we are very much challenged with this issue, especially with our emergency shelters. I don't see that changing in the near future. And so we do need more support from public health and the state to try to address this issue when we have folks we really don't have a setup to really isolate too many of our residents. So we do need some support there. Again, we are willing to pay for a hotel, but hotels will deny you unless you have agreement with the state to come into their facility. So that's the challenge we're facing. It's a big challenge for us at this point. We're dealing with that even as of this morning, trying to work with those clients who have COVID.
Thank you, John, for sharing that. I think it looks like I see from Tarrant, I don't know, those of you who know Tarrant, who oversees shelter at Watcoop People's Place in Kent County, that they share similar experiences related to folks showing up, being scared to divulge their positive COVID status for fear of being unsheltered and COVID positive with nowhere to go. Tarrant, did you wanna add anything there specific?
I wanted to make a suggestion. Is there any way, and I don't know if you have the capacity for that, that you treat everyone that comes in like they are positive and they immediately go into quarantine until you find out that they're negative?
Well, having the capacity to do that is our challenge. We can test everyone going forward. We will test everyone as they walk into our program to determine with the rapid test whether or not they have COVID. But being able to isolate everyone as they walk in the door, that would be a challenge for us as well.
Yeah, and I mean, I would encourage, again, if it's possible, given your facility setup, that if you usually have a room that is shared, make it a 1-person room, and that's any new person that comes in goes in there, right, by themselves. Or again, if that's possible, depending on your setup. Thank you for that, Melanie.
Hi, Rachel. I don't have the ability to come off camera right now, so I do apologize, but I'm tearing everybody. The only thing I would like to share is that unfortunately, we don't have a whole lot of space to do what's being suggested, but we do have a bit of a space when our folk do come in, we can pull them off to a piece of our property to test them. And if they do turn up positive, we get them to the hotel. Now, I'm not sure if the way we handle the hotel process is right or not, but I don't believe we're at liberty to disclose whether that client is positive or not. We just check them in as a normal citizen and go about our business. The hotel and our clients, we recommend that they move forward with practicing universal precaution at all time, assuming everybody is positive. So we don't go into the hotel disclosing that information. And we haven't been turned down or anything like that or gotten any trouble doing it that way. But we have been successful at getting people in hotels until they were negative and then returning back to the shelter. But to tag on to Mr. John's point, if there was a way to do a better job of pre-screening before that referral is made, would be super helpful.
So I think one thing I did want to say is if you are altering any of your operations, meaning have fewer beds, just like make sure to communicate that to our team, and we won't send a referral if they're, if you had a room that normally has 3 people in it and you're changing it to be just a 1-person room for every new person that comes in, that's going to change your capacity, and that's going to mean you can take fewer referrals, and we understand that. So just communicate that. So that, when you have a bed open, you have a bed open. If you need to hold the other 2 that are usually show up in the system because they're not going to be available for the next month, that's fine. Just communicate that with our team. Have your shelter directors communicate that with our team. In terms of screening in advance, we don't really have a way to do that that's useful. We find that we're speaking with folks over the phone and getting as much information as we can, but folks aren't going to share information with us if they think, if they're not sharing information with you when they see you face to face, they're probably definitely not going to share information with us that's going to, that they think is going to impact their ability to access shelter assistance. So I really think the best way to continue is to try to make sure that, again, you are, per the shelter protocol that we have in place through centralized intake, you can require people to have a rapid test to come in. It's just that we ask that you as an entity coordinate access to that testing for the person coming, whether it's that there's a testing site down the road at the local state service center, or whether you have them on site, whatever that looks like. You can do that.
Yeah, that,
I don't know if that helps.
And of course, the issue is we want to help all those who need emergency shelter without question. But what you're saying is what we're going to have to do. We're going to have to reduce our capacity drastically, really, to be able to keep folks well and healthy. Not that we really want to do that, but we don't have much choice the way this thing is spreading.
Right. And so I think that's the hard thing. And I appreciate people wanting to keep as many beds open as possible. Absolutely. Everyone wants that. But the extent to which you need to make a few changes in your programs to keep everyone safe, please do that. And please let us know what, if that affects your capacity. We have folks here to do some trauma-informed training, and I want to make sure we get to them, but I think this conversation is really important. And we wanted to hear from folks over at DHSS. And actually, it says DHSS, which is true, but it's the Division of State Service Center specifically under DHSS. We have Rachel and Chuck here. Rachel, you were going to speak with us a little bit about the status of isolation and quarantine. Isolation and quarantine, I get them mixed up. I apologize. There's a definition on the couple slides back. So Rachel or Chuck, I'm going to hand it over to you to share kind of what you're seeing on the non-congregate isolation side.
Thank you. Good morning, everyone. I'm Rachel Surratt with the Division of State Service Centers Director's Office. I'm speaking on behalf of Director Beeman. Just to give you just some insight, we continue to offer the Delaware COVID isolation program for homeless clients. Right now, we are currently, we have one hotel that will currently take COVID positive clients. So we do that through our resource mailbox. We make sure that the client has a COVID positive test to prove that they are COVID positive and also homeless. So we provide isolation for those clients up to 10 days. Currently, that hotel is the Red Roof Inn in Newcastle. We have cried for help, and we are currently crying for help through DEMA. We have asked them to look statewide and provide us non-congregate sheltering for those clients who are homeless and COVID positive to allow them time to quarantine. So we are on a daily basis looking for hotels and motels that will allow us to place clients there. So as that information becomes available, we will continue to share that. So basically, in addition to that, we have been housing clients since the onset of COVID, and that continues. And we currently have clients in non-congregate shelters statewide, and upwards of, I think we have about 400, and I think the last count was 482 active clients that we're paying for. So that has increased obviously with the onset of COVID. The COVID positive placements have doubled in the past month. Back in the fall, they were pretty much non-existent, and now we have they were in the teens in December. Now we are at that in January. Now we are at that level, and here we are on the 19th, whatever date it is, of January. So with the onset of Omicron and Delta, we are continuing to be strained to find non-congregate sheltering for COVID positive clients. We continue to do the best that we can. I will share in this meeting invite the housing placement, the isolation placement program, along with the referral form. So if you have any questions beyond that, please feel free to reach out to us, and we'll be able to help and answer any questions that you may have. Chuck, did you, I'm going to turn it over to Chuck Hayward, who's also with DSSC, to add anything that I may have missed.
No, I think Rachel did a great job of sort of explaining where we are at this point in time. As many of you know, with the progress or the whole change that has occurred because of COVID, you know, we have had to go back and redouble our efforts in a number of areas. As you know, last year when COVID hit, many of the hotels and motels were at the point where they had no business. So they were willing to take our folks. As things began to open up a little bit, especially downstate, the two hotels that we were using for quarantine have said, you know, we're not going to take these anymore. So that has been a problem that we, as Rachel said, we're trying to replace those hotels and motels. So we're looking at with public health and with DEMA, trying to find some other locations. You know, at one point, Governor Bacon was open for a short period of time to take clients. So we're looking at possibly doing something there again. But, you know, opening and closing a facility like that is not an easy thing to do. So we are pressing for some of those kinds of things. I think the other thing that, you know, and Tarrant mentioned it, you know, sometimes you just have to be resourceful. You know, you just take somebody, you put them in the hotel. Hopefully they are going to follow protocols, are not going to be walking up and down the halls. And one of the things that we try to look at is some of those hotels and motels where you have an outside entrance, so you don't have to go through a lobby and that kind of thing. So as you're looking for places like that, that would be one of the recommendations. That way, at least you can somewhat control the spread if somebody does come in and out of the hotel room. You know, we were at the point where we almost had, you know, we had very few people who were coming in, and then that all changed again. So, you know, in addition to the additional people who are coming in and the fact that we don't have as many hotels and motels willing to accept COVID positive, you know, it's put us in a kind of the same bind that you all are in. You know, thank goodness we've worked very closely with the folks at the Hope Center so that we can move some of our people into the Hope Center and make some of the other hotels and motels available. But again, we just don't have the spots that we had early on during the pandemic.
Thank you, Chuck. Thank you, Rachel. If there's any way that you think the COC can be helpful in that, let us know. You know, we have a of course, a board and a membership full of folks who really care and want to help. So please let us know if there's anything that the COC can do to be helpful in terms of getting access to additional units, which I know I can't imagine the work that you all are doing right now. So thank you very much. I think we are over time to start with our training portion, but I want to make sure that if anyone has anything additional to add, John, if you have any additional questions for Chuck or Rachel, that those get answered before we move on.
No, we'll keep pushing forward, doing the best we can to make sure folks are safe and healthy, including the clients that we serve, volunteers and staff. That's what we do, and we'll continue to do so. If we can get some support from anyone, we accept that also. So thank you.
Thank you, everyone, for what you're doing, and feel free to reach out if there's any way that we can be helpful. I'm going to now ask everyone, if you haven't done so yet, to probably stand up and shake your body around a little bit if you're planning on staying for the training. We've got folks here from Pathways to Housing who are going to be, so we're going to shift gears a little bit into training mode. So feel free to stretch, move around, use the restroom, and I'm going to hand it over to Pathways.
Hi, everybody. Good morning. It's still morning. It's a little sunny outside today in Philadelphia. I hope you're getting some of that in Delaware. We're happy to be joining you all. I see some familiar faces, some friends I haven't seen in a while. Good to see everybody. Our slide says it's going to be me and no, I am Andrew. I need more coffee. Me and Rob Weatherington today, but in fact, it is myself and my colleague Ryan Villagran who are going to talk to you a little bit about trauma-informed care. Can we have slide sharing capacity? Is that possible? Ryan's going to be the one sharing the slides, so if he could be made a co-host, that'd be perfect. In the meantime, I will tell you a little bit about who we are and what we do, just in case we haven't had the pleasure of making your acquaintance yet. So Pathways to Housing PA is a homeless services organization. We're based in North Philadelphia, and we've been using the Housing First model to help end chronic homelessness for single adults living with serious mental illness and substance use disorders, physical disabilities, etc. We've been doing that since 2008. And the folks that we work with are really the folks that are considered sort of, not ready for housing or not motivated for treatment by other providers. And what we found is when we provide somebody with a home and then the wraparound supports necessary for them to be successful, we have an 85% housing retention rate after 5 years with those folks. And so Housing First University is our outward facing training and educational initiative where we talk to other folks about the Housing First model, harm reduction, integrated care, and service delivery best practices. So certainly the trauma-informed approach and providing services that don't re-traumatize people is a part of that work. So I'm the Director of Training and Technical Assistance here at Pathways, spearheading Housing First University. I've been with Pathways for about 4 years now. I started out in a direct service position as an assistant team leader and then later a team leader. I've been doing this role for about 2 years now. And it's really great to get to talk to folks in other communities who are doing similar work, have similar passions, and just getting to connect with y'all. So I'm going to toss it over to Ryan to say hi real quick, and then we're going to get into it.
Good morning, folks. My name is Ryan Villagran. I am a training specialist with Housing First University, started this summer. My lens that I'm kind of approaching this conversation today through is my work in inpatient and outpatient mental health settings earlier on in my career. And then I've also spent time in a university setting, sort of delivering training content and material. So really excited to be here talking with you today.
So let's take a look at our agenda. We have a heavy lift for 45 minutes, 44 minutes, but we are going to attempt to talk about, what is trauma, common sources of trauma, the adverse childhood experiences, the ACEs study, I'm sure a lot of y'all are familiar with. We're going to talk about the 5 R's of trauma-informed care, some key components of trauma-informed care, and then maybe we'll have time for some questions at the end, but that's pushing it. So we'll encourage you in the meantime to utilize the chat for as many questions as you have coming up throughout the presentation. And I'll try to tackle those while Ryan is presenting so we can multitask a little bit. Is it just my screen that's frozen, Ryan? Because I'm still seeing the intro slide.
Oh, let me stop the share and restart it. I wrested control from the folks earlier, so let me try again. How's that? Are you seeing?
Are other folks seeing the slides? Okay, I am now. I got it. So our learning objectives, great. So 3 things that we hope you'll be able to do after you walk away from this session. 1, define what trauma is and some common sources of trauma. 2, understand the 5 R's of trauma-informed care. And lastly, describe the key principles of trauma-informed care. Ryan, that screen share just disappeared for me.
Sorry about that. Zoom is causing me some problems.
All right, I got it as a backup if needed. And then lastly, our housekeeping. Do you have, there we go. 1 hour session. We might go over a little bit. This is being recorded. So if y'all have to jump off for another meeting, you'll be able to access the last couple of minutes later. So we'll get you all the information. If you're able to turn on your camera and be present with us, we would love to see your faces. That helps us know if we're doing a good job and we're kind of hitting the nail on the head, or if we're just kind of confusing everybody and we need to like pivot or repeat something or explain something better. So yeah, we don't mind if you eat your lunch or if you're snacking. I'm probably going to do the same. So, you know, be comfortable. We're all friends here. Since we do have a quick session, we're going to ask that you drop your comments and questions in the chat and just remain muted when not speaking to keep the background minimum. Y'all are all Zoom experts by now. We've been doing this for 2 years. We're going to provide certificates of attendance to folks who stay with us for the entirety of the training. In order to get one of those, we're going to drop a link to a course evaluation at the end of the session. Answer those questions for us. Give us some feedback about how we did. We look at every single one of those and incorporate that information so that we can, you know, deliver the best trainings possible. So complete one of those and we'll get you a certificate for being here today. And then if you have any disability accommodations that you might need, I'm pretty sure we can enable closed captioning in the training. You can also just send me a private message and we'll see what we can do. So with that, Ryan, I think you'll take it away and talk to us about some trauma-informed care.
Great. So we're going to start off with just kind of defining trauma, understanding, you know, where it comes from, what it's all about, how it affects people. And so I want to kind of toss up on the screen. This is SAMHSA's definition of trauma. One other way of thinking about this is the 3 E's of trauma, and you can see those E's underlined here: event, experience, and effect. So let me read that. Individual trauma results from an event or a series of events or a set of circumstances that is experienced by the individual as physically or emotionally harmful and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. I think a kind of a key here is that, you know, trauma is not something that someone else can define for you, right? Or you can't define it for someone else. It's kind of a subjective experience in some ways, in that if I experience an event as physically or emotionally harmful, it is what it is, right? You know, it's sort of difficult to sort of point at somebody and sort of look at what's going on for them and say, you have experienced trauma. Now, it may be possible to sort of infer some things, but certainly we can't sort of look at somebody and say, no, what you're experiencing is not trauma. What you went through is not trauma, right? So it's a very personal, individual experience. And it can be, again, like a specific single event or a set of things that's occurring in rapid succession, or even a set of circumstances. And we'll talk a little bit about the ACEs study later, but the sort of impact of community level trauma, as opposed to sort of a specific individual event that happened to a person. So the 3 E's of trauma, there they are. And just a kind of a quick note, when we talk about the word trauma, that comes from a Greek word meaning wound. And so while kind of in the older days, trauma was really meant to refer to kind of physical injuries, nowadays, I think it's just as likely or more likely to refer to kind of those emotional wounds, but either would sort of match this definition. To dive deeper into a traumatic event and what it is, you know, a traumatic event is one in which a person feels terrified and helpless. And so these kind of key elements of a traumatic event are this loss of safety and a loss of control. You know, if you have experienced a traumatic event or you've worked with folks who have experienced traumatic events, I think you can kind of key in on these ways that a person felt a loss of safety and a loss of being able to do anything about it, right? A loss of control. It is really outside of a person's control and really kind of terrifying to experience a traumatic event. And I think, again, I want to keep referring back to this idea of community level trauma. Certainly a loss of control when things are happening at the community level. And then the loss of safety is much less kind of terrifying in the moment. You know, it's not that plane crash that a person was in or something like that, but sort of a ambient level of loss of safety as somebody moves through their life. Some examples would be exposure to death, serious injury, or sexual violence. Want to take a moment here to note that while it is possible to directly experience a traumatic event and have a traumatic sort of adverse effects that occur as a result of that, it's also possible for a traumatic event to be defined by something that a person witnesses, right? And so, you know, I saw a car crash occur. I saw a gunshot victim, you know, I saw that occur in front of me. Or even perhaps this next point here, where we learn about an event that occurred to a close friend or a family member, right? So a person can experience trauma, can have a traumatic event occur to someone else, and we learn about it, and that can have an adverse effect on us as well. And then kind of just this other piece here where it's repeated or extreme exposure to aversive details of an event. So again, maybe I didn't experience the event, but I keep hearing about it. And I keep hearing the sort of gory details about what happened there. This really applies to us, of course, as service providers, right? We want people to tell us their story. We want to sort of help people process through what they've experienced and develop some skill, help develop some skills, coping skills to deal with those things. And so we often hear these events in great detail, perhaps little by little, over time, perhaps the same thing that a person is sort of really stuck on and is having a hard time kind of moving through. And so for us as service providers, it's also possible to have a traumatic event impact us that really wasn't our event per se, right? But we've heard about it so frequently. And so in terms of the way that these traumatic events affect us, these adverse effects that 3 E's definition showed us, a number of them here. Some of them are probably familiar to you if you've worked with participants for any length of time. You know, agitation and anxiety, extreme startle reflex. I won't read all of these to you, but I see kind of clusters of these in the folks that I've served, right? A couple of come here, a couple of them here. And I guess a key kind of note that I want to make about the way that people experience trauma, the way they sort of respond to it, is that these are all sort of very normal and adaptive responses to trauma, right? Like a person doesn't experience flashbacks and you say, well, you're doing it wrong. Like you're kind of trying to move through the, no, it's just like a normal thing that happens to human beings when they've experienced traumatic events. And these things are adaptive responses. I will also say that it can be easy if you're not kind of approaching your work through a trauma-informed lens to experience a participant kind of coming through the door and they're really agitated and anxious, you know, always in distress. There's kind of like never a level of calm and peace for a person, maybe ongoing sadness and depression. And it's easy to sort of like identify those things and say, okay, well, they're just like a depressed person. They're just really anxious. They're high energy, always agitated, and that's a problem that we can work on and get them to move through that. And sort of miss sometimes that these are symptoms and responses to traumatic events that people have had, right? So it's easy to sort of, if you don't have your trauma-informed lens on, to look past that. There may be something that has happened to a person that has caused this set of symptoms and responses. And so when we sort of keep that in mind, we can sort of engage a higher level of empathy and understanding about what people are going through. In addition, when people experience traumatic events and those adverse effects, there are a number of losses and consequences that can occur for folks. And so when people experience these events, you know, it would be typical to experience a loss of trust and an injured sense of self, or perhaps a loss of safety, as we talked about earlier, which can look like hypervigilance for somebody, sort of always on alert, a loss of their own sort of sense of identity and hope, and capacity for intimacy, right? So this level of sort of withdrawal from society or from their inner circle or from their sort of typical support networks. Additional kind of consequences of some of this can be, increased substance use. Perhaps it can lead to homelessness. Of course, a sense of loneliness, even if it can't be sort of voiced that way, verbalized that way. Perhaps it can lead to exacerbation of serious mental illness, additional restrictions and avoidance in the way that they live their lives, perhaps not leaving the house, an inability to sort of maintain regular work or employment, and it sort of really damages those relationships in a person's life. And in addition, it can lead to chronic physical illnesses. And so there are all these sort of things that people go through, especially some of the folks that we serve who have lived in poverty for many years. And it's easy to sort of forget that these are all connected. And sometimes the unifier is sort of the traumatic circumstances that people have lived through. I want to spend just a few moments talking about the Adverse Childhood Experiences Study, otherwise known as ACEs. Many of you are probably familiar with this, but it was a longitudinal study that was in partnership between CDC and Kaiser Permanente. It started in 1998 and it had over 17,000 initial participants. So this is an enormous study across the United States in terms of what people have experienced in their childhood. It had 10 measures initially, and it was really kind of individually focused, like things like, is there someone in the child's home that uses substances? Is there someone in the child's home who has been incarcerated or is currently incarcerated? Has there been domestic violence in the home? Things like that. And so, what we saw was that there was a really strong association between having a higher ACE score. In other words, people that sort of indicated, yes, the child experienced that. Yes, that occurred in the home. When you had multiple of those sort of ACE indicators occurring, it was a really strong association with negative physical and mental health outcomes later in life. And so it can be sort of possible to, in some ways, predict when X, Y, and Z happens in the home for a child, these sort of traumatic events, it's very likely that there is going to be X, Y, and Z physical and mental health manifestations of that trauma later in life. And so it's a really sort of just a good indicator of the way trauma impacts us across our lives, across people's lives. The sort of more recent additions to the ACEs study have started to include less kind of individually focused measures and much more sort of environmentally community focused measures in terms of community level violence, et cetera, poverty. And so the ways that those are traumatic events for people also show strong association with some of these negative physical and mental health outcomes.
Ryan, we have a question in the chat, and you tell me if you think that you're going to address this in some upcoming slides. But Rachel asked if you could distinguish between being trauma informed and actually addressing trauma with people. In other words, under what circumstances would you recommend someone asking someone, a client about trauma history? I think sometimes people can think they need to or should do this if they are trauma informed, when maybe it's not always a good idea.
I actually agree with you 100%, Rachel. There's a distinction when you kind of look through these materials, and no, we don't really touch on this very much, especially because it's such a short training. But there is certainly a very distinct difference between a trauma-informed approach and trauma-specific services, right? Services that target trauma and that are interventions developed specifically to help people move through that trauma. And so that's really not the focus of this training. We want even folks who are not specifically addressing trauma using specific evidence-based interventions for trauma to still have a trauma-informed approach. And we'll see the ways that that approach is both held at the individual level and our kind of organizational level. We want to sort of key in on some principles for the way that we can approach. And so I think if your organization's mission is not to specifically address trauma, I would doubt that sort of you have the tools that you're in your tool belt for sort of what are those interventions, and are the folks that work here trained in those interventions. And so we want to make sure that we're making appropriate referrals. Certainly trauma is a part of many of the people's stories that we serve. And so that's why we want to sort of have a trauma-informed approach. But as we get into the meat of what that is and the way it's impacting people's lives, there may be room for a specific referral for a trauma specific intervention. So I don't know if that answered the question. Go ahead.
I think it did, Brian. I also wanted to add, I think a way that we can, sometimes the way that we practice trauma-informed care is specifically by not asking folks to kind of rehash their story again and again, right? When folks are getting referred from agency to agency, they've already done 13 intakes over the last 10 years, everyone requiring someone to kind of retell like the nitty gritty details of their trauma is actually re-traumatizing for folks. So, I think a takeaway from that is, sometimes the best way to practice trauma-informed care is by not to ask those questions in the first place, especially if it's really not relevant to the work that you individually are going to be doing with that person.
Yes, and just to add on to that last statement that Andrew just made, it is likely going to be relevant in some way to the work that you're doing with folks, right? Because the folks we serve are, have a chronic history of homelessness, for example, and like what caused that? Well, I would be hard pressed to, to imagine that there wasn't trauma in there. But again, are we specifically here to work on that, or are we here to sort of have a trauma-informed approach that can sort of hold some of that while we get more specific interventions for those folks? And so this is a big challenge. The ACEs study kind of showed us that so many folks have experienced such a high degree of trauma in childhood, and folks experience trauma throughout the lifespan. Is it possible to do anything about it? And what is that we can do? Well, sort of one of the keys, I mean, I hope it doesn't sound too reductive, but one of the key ways that people can overcome traumatic experiences is through developing and having appropriate and sufficient internal and external supports. Okay, we're talking community here. We're talking kind of basic connection with human beings. And so there's nothing sort of rocket sciencey about that, but it's key because many of the folks that experience traumatic events do go without effective supports, right? So if it's as simple as making sure that there's appropriate supports in place, it's also true that that doesn't occur for many of the folks that we serve. And one of the reasons why that's true is that trauma, in fact, inhibits our ability to connect with others. We saw those symptoms and responses, that loss of trust and loss of safety on some of those earlier slides. Well, all of that sort of serves as a barrier to connecting with other people and finding those external supports and even internal supports. And so you can see why it can be difficult for somebody to even make the leap of knowing what to do when they face trauma in their lives. So part of what this would be helping people to connect with community resources and build new networks or strengthen the existing networks that they have. And they can really use our sort of professionalized support in doing that, helping guide that process and pulling them along and holding their hand while they move through this process. So we're going to spend some time talking about trauma-informed care. What is trauma-informed care? And this is that distinction that we talked about where, there are trauma-specific services or trauma systems, and there's sort of a trauma-informed approach, which is what we're talking about here. And so trauma-informed care is a practice that's based on the assumption that an individual is more likely than not to have a history of trauma, right? And the ACEs study sort of serves as the foundation for that. So many folks have experienced trauma. I think it is safe to assume in our service delivery systems that somebody has a history of trauma, right? Assume that they do rather than that they don't, if you're going to make an assumption in that way, because it is so likely that they have. And this applies to staff and clients. And so as we kind of continue talking, we'll see the way that trauma-informed care is not just about the way that staff are interacting with clients. It's about the way the organization partners with their staff members and a way the staff members reflect the values of an organization. And so many of the staff members, I think it's a tale as old as time, right? So many of us service providers have come to the field having a history of trauma. And it's like, I want to help. I want to each one teach one a little bit here, right? I want to sort of put my hand out to folks that need a little support as well. And so we can see that trauma affects people across the kind of service delivery system. Trauma-informed care also recognizes that people who have experienced trauma may have beliefs that interfere with their motivation to receive supports. And this is what we were talking about a little bit on that previous slide, where, if people have experienced trauma, there's probably stuff that's getting in the way of them kind of connecting with their appropriate supports, or even sort of demonstrating the motivation to connect with those supports. And so, of course, trauma-informed care requires a great deal of patience and care and just sort of a welcoming attitude that allows for people to sort of not be in a space where they're ready to feel motivated to receive those supports, and we sort of stay with them through that process. And then lastly, trauma-informed care delivers services in a really sensitive way that's designed not to re-traumatize. And this goes back to what Andrew was talking about a little bit, where, you know, if we're sort of continuing to prompt people to tell us their traumatic story over and over again, and that's not in the context of a specific trauma-focused intervention, you know, what is it likely that it's going to re-traumatize them? Is the physical space of our environment one that is similar to the event that caused the trauma in the first place? And could we redesign our admissions flow, or like our milieu space, our congregate space? Are there ways to make sure that we're not kind of piling on additional trauma while people are here to help to be seen to kind of move through some of these issues? So I want to kind of highlight 5 R's of trauma-informed care. And these are basic assumptions that if a sort of an organization says, yeah, we are approaching things through a trauma-informed lens, we're all about kind of trauma-informed care and making sure that we keep those earlier principles that we talked about at the core of what we do, then if the organization's saying that, then we can assume that they're kind of practicing these 5 R's, or that they are working towards that. So the first one is realization. And this is that all people at all levels of the organization or the system understand how trauma can affect individuals, families, and communities. And so we're here kind of as a continuum of care, as a sort of a full system of services here in the state of Delaware. And if we can't sort of together or individually recognize the way that trauma impacts individuals, families, and communities, and draw a straight line between the trauma and what people are experiencing, then we need to do some digging there, right? We need to sort of come to a realization. Many of the policies and systems that we interact with may need to be reshaped with that realization in mind. I know that we've got kind of a range of delivery of services here, but here at Pathways, with a housing first model, one of the things that we have realized is that folks are going to go through at least one move once we house them initially, right? And so it's this understanding that they've built up sort of survival strategies over the years of chronic homelessness, of living on the streets, of bouncing around from couch to couch. And that's going to impact the way they engage in their new housing. Yeah, there's that one dude that loves to take stuff apart and is probably going to sell pieces of his appliances on the street for some extra cash. Okay, that is sort of built into the cake here, right? Understanding, realizing that trauma affected this person in that way. And so we understand too, and our policies reflect that we may need to move somebody again, and perhaps again, and maybe even again after that, understanding that these survival skills are deeply embedded, and that's an impact of the trauma. You know, some folks may be so mistrustful of the homeless service system that we might even have to do some outreach. You know, we've got apartments ready to go, right? I meet you on the street. If you're ready to get into housing, we might have you in housing within 2 weeks. But some folks, that's not going to work. They've experienced too much. And so we might do outreach with those folks over the course of several years, not discharging them, not writing in our notes that they don't want housing and we're ready to move on. Now, we sort of understand that this is baked into the cake, and that realization is there. And so we're going to keep trying to make those connections, keep attempting and working to build meaningful relationships until they're ready to say, yeah, I want an apartment now. The next R is recognition. And this is where we sort of recognize the way individual participants and staff members might be expressing signs and symptoms of trauma. And so it's so easy to sort of fall back on, oh, they're resistant. Oh, that staff member never gets their notes done. They're just disorganized, and this might not be the field for them. Well, if we realize the way trauma impacts folks, we can start to recognize that what we're seeing in folks is often the result of trauma. We can recognize the signs and symptoms, some of those ones that we saw on that earlier screen. And so part of this is that we need to continue to sort of assess participants regularly using a trauma-informed lens, saying, hey, is this an impact of trauma? And sometimes it's hard to know, right? Especially early on, we don't know a person's full story. We don't necessarily know, but it's good to sort of keep that in the back of our head. I wonder if that's a sign or a symptom of trauma, rather than just sort of resistance for resistance' sake, right? Which doesn't really make sense. There's always a reason for what people experience. And part of that recognition also includes having ongoing training and supervision, checking in about this stuff. So for staff, group and individual supervision is a crucial way of sort of identifying and recognizing signs of trauma or secondary trauma. And you can get a clue into this in terms of, how are people talking about participants? Are you hearing a lot of sort of burnout sounding language? Are they sort of frustrated and angry at participants? These are potential signs and symptoms of trauma or secondary trauma. And so that's why that supervision process is so important as a way of assessment, not in a kind of clinical sense, but just like supervisor to staff, like what's going on with this person, and is what's happening for them a result of secondary trauma. I want to just quick pause here, and I see some stuff happen in the chat. Do you have any questions, any comments? What's going on over there?
Ryan, I think that was mostly related to folks wanting to make sure they could access the materials after the training at this point.
Perfect. Awesome. Thank you so much. All right. So the next R is respond. So we've sort of realized that there's this widespread trauma that has occurred in many of the participants and staff members' lives. We're starting to understand that we can recognize behaviors and ideas and the way people talk as potential signs and symptoms of trauma. And so now we have an opportunity to respond. And so in a trauma-informed approach, having agency policies, procedures, and actions calibrated to trauma-informed best practices is key. And part of that is sort of the natural evolution from realizing and recognizing to doing something about it. So if you can sort of realize the impact of trauma and start to see signs and symptoms of it, how are we going to respond as an organization? And how am I going to respond as an individual? And it's sort of related, right? This idea of ongoing supervision for recognition. Well, making sure that the supervision schedule is weekly or biweekly or is very consistent. Having a commitment to physically and psychologically safe environments. If you could sort of look around your environment and say to yourself, like, does this feel safe? Does this feel safe physically? Does it feel safe psychologically? And if the answer is no, what needs to change? How do we respond to that? And an organization should also be supportive of connection. What does that look like? Does it look like staff retreats to kind of develop better working relationships and sort of and have a safe space for people to connect with one another, that external support that we talked about before. Some of this can also look like having kind of low barrier to entry policies for folks, right? And that's the basis of Housing First. No other preconditions for housing. Just let them on in. If someone expresses an interest in opioid use disorder treatment, medication for opioid use disorders, we want to get them seen that day, right? Sort of very responsive to people's needs, but not pushing them. Sort of a safe, comfortable, calm, relaxed way of approaching things and empathetic. But when they're ready, we jump on it. This can also include really kind of a key commitment to person-first language and staff's ability to reflect this belief and resilience and recovery. It can include kind of ongoing training for trauma-informed care. It's not just a one and done, but it's having principles outlined for us like today, but then coming back to them and saying, wait a minute, did we do anything to recognize and respond? And if not, what's next for us? And it's sort of an ongoing process. And then respond also sort of captures this idea of modeling and teaching emotional regulation. So, we want to make sure that we are emotionally regulated. We're practicing kind of mindfulness in the way that our emotions come out in our work. And that serves as a model for the folks that we serve who come in anxious and agitated as a result of what they've experienced. And so hopefully we can continue to model some of this emotional regulation for the folks that have experienced a great deal of trauma. The next R is resist re-traumatization. And so this is really that organizational awareness that some of our practices could potentially re-traumatize folks. You know, having done work in inpatient settings, I know that sometimes it is necessary to get somebody into a hospital setting. Perhaps they were threatening to hurt somebody or threatening to hurt themselves, and there was sort of no other recourse. We've reached a place where they were involuntarily committed. But that has an impact on people, right? The way that we make that call. Are cops involved? Did they slam them to the ground? You know, when what they've experienced is mental health symptoms. There's just a ton of re-traumatizing stuff that can occur in the services that we provide. And so we want to be really aware of those potential touch points, those hot points for re-traumatization. Staff training would prioritize trauma-informed support. So having kind of routine processes with really clear expectations. When staff don't know what to do about a situation, when they don't know the policies, when things sort of change rapidly underneath them. And sometimes that's unavoidable at the organizational level, right? Just stuff is just happening and we have to respond to those changes. COVID is a great example, but sort of putting in place routine processes with clear expectations can help to resist some of that re-traumatization. We'll work to minimize triggers. If kind of extremely loud noises in a space are triggering, can we have multiple small spaces for congregation? Can we make some quiet spaces for people to go to? We'll prioritize consent in everything we do, and that's work with our clients as well as with our staff. And so you can see the way that there's this parallel process between an organization and the staff, as well as the staff and a participant. Just an example here, many of the folks that we serve who access opioid use disorder treatment, they can be really surprised, right? If they've done Suboxone or methadone in the past, they can be really surprised when they show up to see us and they don't have any Suboxone in their urine, right? Which would be an indicator that they're not taking it. They're not sort of effectively using the treatment. And we don't kick them off the program. Whereas in other places, they've been kicked off the program. There's no Suboxone in your urine. You must be selling it. You're out of here, or a 3-strike policy or something like that. And so they can be surprised when we don't kick them off the program and they don't feel those screws tighten, that accountability tighten, because they're used to really rigid expectations that may not actually help them in their recovery. And so just an example of resisting that re-traumatization, of being kicked off a program, and another example of them failing, which sort of just reinforces their own negative sense of self and perhaps increases their use. And then we'll make sure that we're using the physical environment as an intervention, as we talked about before, having quiet spaces, safe spaces, calm spaces, not crowded spaces, large enough spaces. There's so many ways that we can use our physical environment as an intervention. And then the last one is repair. And this assumption sort of recognizes that we all make mistakes. There are times when we're going to hit somebody's trigger, even if we knew that was a trigger. We're kind of programmed to do things a certain way, and we go on autopilot sometimes. And so we will make mistakes. We're going to trigger folks. And so the important part here is that we acknowledge when that happens, and understand that it's an opportunity to strengthen the relationship, where I can sort of say to somebody, hey, I realized that was a trigger for you. I just want to apologize. That slipped my mind. I wasn't kind of keyed in on that at that point. And I want to talk with you about, if that ever happens again, what can we do together? What's our plan for how to kind of move through this? There's an opportunity to strengthen the relationship, develop a stronger rapport, and continue working in an effective way with folks. Repair is focused on safety. And sort of working to bolster our commitment to trauma-informed care. When we make mistakes, and we will, what are we doing at the organizational level to assess ourselves? What practices do we need to review? What training do we need to add for folks? And as usual, it sort of models trauma-informed care for clients as they move through their lives, right? That those apologies, those acknowledgements of mistakes, and the working to fix those mistakes, again, can serve as a great model for folks in their day-to-day lives. All right, so those were the kind of key assumptions about trauma-informed care. If an organization says that they are practicing trauma-informed care, we hope to be able to sort of assume those 5 R's. Additionally, there are 6 key principles of trauma-informed care that you can use to kind of embed this into your organizational culture. Number one is safety. And so do a quick scan of your workplace. Do you feel safe? Do you feel safe physically, psychologically? Are there many options and choices about how to engage with that physical space? How do you think your clients feel? Put yourself in their shoes. They've been through the service delivery system for a long time now, perhaps, or maybe this is their first time through. Well, how do you think they feel? Engage with them. Talk with them about that. What does it feel like to come through these doors? What does it look like to approach that first point of contact at the reception desk? What does it feel like to be walked back to an office to talk to somebody? There's a lot to sort of examine and understand. Put yourself in people's shoes. Is the physical setting safe? Is it orderly and neat? Is there anything we can do to sort of enhance the feeling of safety in that space? Or is it chaotic? Is everybody so busy and that it feels like people are running around with their, like chickens with their heads cut off? Really important things for people to experience. And some of this is really individualized, right? It may not be possible to sort of avoid every, people might have conflicting triggers, for example. Some are triggered by quiet spaces, some are triggered by loud spaces. But we work to sort of do our best here. Do the interpersonal communications in our space promote a sense of trust and care? Or is it warehousing people? Is it moving them through as quickly as we can? And another sort of way that we do this, implement safety, is learning about participants in advance when possible. Learn about their triggers. Understand what we can about what they've experienced and how we can avoid some of those things. The next principle is trustworthiness and transparency. And so this is where we work to make sure that our services are transparent. There are no surprises, right? We can sort of walk down services from top to bottom and help people understand what they can expect. We try to do this during outreach with folks on the streets. We want to get you into an apartment if you're ready between 2 and 4 weeks from now. What we need to do is make sure we keep the we've done a kind of a clean sweep of the apartment. We make sure there's no broken furniture in there. We want to make sure you're ready. We get you a full kind of move-in kit. We want to make sure you have furniture. And so it's not a surprise to people when they finally make that move in because we've walked them down from top to bottom what they can expect. So avoiding surprises is key here. We want to make sure that decisions are made with transparency. I've been a part of sort of service delivery where there's conflict between participants. And a supervisor sort of looks at that conflict and sort of makes a snap decision. And it's not really clear why they made that decision and why did they make that decision against that person, but not that person. And so making decisions with a level of transparency and openness can serve to develop more trust, help people feel more safe, and not be re-traumatized. The goal of building and maintaining trust among clients and staff is met when we're sort of approaching things with trustworthiness and transparency. And so I would ask you to reflect, how do you establish trust with your clients? Is it just at the individual level? Is the organization doing anything? Do you have policies about when you should do outreach and how frequently? And what happens if that trust is broken? Making sure that we're not giving up, we're acknowledging that we dropped the ball and we work on the repair. The next key principle is peer support. And this is just so important in the work that we do here at Pathways. Having folks that are able to connect with people at the peer level is crucial. Having space for peers to come together and share knowledge, peer support, mutual self-help, that's a key vehicle for establishing safety and hope. If a person looks at a peer support specialist or some other peer and says, wow, look how amazingly they're doing. I wonder if I could do that too. What a nice message for them, right? I can move past what I've gone through. I can achieve a level of stability and safety in my life that they have achieved. We understand already that lived experiences promote recovery and they promote healing. And so people's experiences are part of them. We want to acknowledge those things and we want to sort of understand that they can build on those things as tools, as strengths, what they've gone through. And we use peer support to help highlight that message. Peer support also helps us resist that expert mentality, right? It helps us understand that we don't have all the answers for people's lives. We haven't lived in their shoes. The therapist with the letters after our names, we're not the end all be all. And so we can resist that expert mentality and kind of work with people on a level that they're comfortable with, right? A level of collaboration rather than talking down to people. The next one is collaboration and mutuality. And so this is where we work to level the power between staff and clients. I've been a part of organizations that have done a really poor job of this, where they're kind of the staff are up on a pedestal and like the clients really don't care for the staff. That relationship can't be developed in key ways to help people move through their traumatic experiences or to work towards their goals. I've also been a part of organizations that do a great job of allowing staff to just meet people where they are. Finding ways to level the power among staff also, right? Or is it like a very top-down, hierarchical, the C-suite is up in the clouds kind of thing? Or are they like real people that care about their staff members and care about their participants? This is key as well. Having a level of shared decision-making. We see this in effective goal planning, right? Where it's not a treatment plan written by a therapist anymore, that we understand that doesn't make sense. It's 2022. We're working with people on their goals and we're helping them kind of weigh the pros and cons of decisions. This can also be true at the organizational level. I think it can feel like a radical idea to share decision-making with staff. And yet I think as a sort of a trauma-informed approach, we can see that it develops a greater degree of that transparency, that collaboration, and it helps sort of people buy into the mission in more effective ways.
One moment, Ryan. I just want to let everyone know that Ryan, well, it's 12 o'clock now, and just want to give Ryan just, a few more moments to continue, but just in case if anyone had to hop off. But we are aware of the time, and just he wanted to, finish the presentation. Okay.
Yeah, thank you so much. And we are coming to an end here. If you need to hop off, you won't hurt my feelings. So let's keep moving here. The next key principle of trauma-informed care: empowerment, voice, and choice. And so this is where we kind of recognize people's strengths and we build upon them. Similarly with peer support, right? We understand that lived experience is crucial, but those are strengths, not weaknesses for folks. This is that fostering belief in a person's ability to heal. If the staff member can't be kind of hopeful and help somebody feel empowered, how can the person who comes through the door sort of expect to set their sights high in terms of the direction that they're moving in? We understand that trauma-informed care can be a unifying aspect in the lives of agency leadership, direct service staff, and those seeking services. It's a culture that you can buy into, trauma-informed care, which enables such a high level of empowerment and enables that voice and enables that choice. This principle sort of acknowledges that staff are facilitators of recovery rather than controllers of recovery, right? We have some tools that we can help people with. We can partner with them along the way. We can do shared decision-making, but really our kind of key focus is empowering people to do it for themselves with our support. Trauma-informed care sort of also it acknowledges the cultural, historical, and gender issues that are at play in our service delivery system. And so we're working to actively move past stereotypes and biases, doing work around cultural humility, recognizing cultural opportunities when there are differences between staff and the participants that they serve, or between staff members, or between leadership and staff. And so trying to move past stereotypes and biases and acknowledge strengths along the way. We're offering gender responsive services that sort of not sort of putting people into this old traditional binary or putting people in a box. What do your assessment documents say about some of those things? It also incorporates policies that are responsive to the racial, ethnic, and cultural needs of the clients and recognizes and addresses historical trauma. Okay, so here's a review slide. That was the really quick and dirty version of trauma-informed care. We have some lengthier discussions that we can have if you're interested, but just as a review. An event can be traumatic when a person experiences a loss of safety and a loss of control. Trauma-informed experiences can be overcome through internal and external supports. The 5 R's of trauma-informed care, those 5 assumptions, those operate at both the individual and the organizational level. And so there's a parallel process that we've talked about here. And then the 6 key principles of trauma-informed care are an approach rather than a specific set of practices. And so you can see that it didn't really offer anything really concrete about, well, what do I do in my shelter setting? Well, it's an approach. It's not a task-based set of practices. And it requires a lot of kind of critical thinking at the organizational level to implement something that really works. All right, I'm going to take a breath.
Yeah, I wanted to add to that last thing you said, Ryan, is I feel like that's a kind of a wall we run up against in a lot of the things we talk about and train about, right? Like housing first, harm reduction, trauma-informed care, crisis intervention, de-escalation, rather than being like kind of like a prescriptive, this happens, this is how you respond. It's really about kind of like a philosophy or a mindset of the way that we approach different situations with our participants, right? And part of that is because we're recognizing that we're working with individuals that have different strengths, different barriers, different internal and external resources, different trauma, et cetera, et cetera. So yeah, lots of other conversations we could obviously have within this topic, but that's our very quick version of trauma-informed care for y'all. I dropped the link to the session evaluation in the chat. If folks would like to give us some feedback, we can also give you a certificate for being with us here for an hour of training time, if that's something that would be helpful for your records. So all questions, comments, welcome. We can stay for a couple of minutes to answer questions if need be, or you can drop them in the chat and we'll get you back via email. So.
Thank you so much, gentlemen. Were there any questions? If so, if you could just raise your hand if you didn't put it in the chat, and then I can address anyone. Any questions? Okay, thank you again, gentlemen. And did you state you put your email in the chat?
Oh, sure, we can.
Okay, just in case if anyone has any questions later.
And we will be sending out all of these materials to everybody through email, and we will also be including them on the website for anybody to access at any time.
Okay.
Yeah, thanks, Erin. I'm going to send y'all a tip sheet with the 5 R's of trauma-informed care that you can send out to everybody as well or post on the website.
Perfect.
Thank you.
Actually, right before we close, give the floor to Erin. Did you have anything to add before we adjourn?
No, that was all we had for you guys. The next meeting date is going to be April 20th, 2022. And we will be sending out reminders and everything for that as it comes. And if you guys have any questions about membership or anything COC related, our contact information is there.
Thank you again, everyone.
And thank you for attending.
Yes, thank you. And we will go ahead and adjourn the meeting at 12:06. Everyone have a lovely afternoon.
Thank you.